Hello, everybody. I'm going to get started. Just a few housekeeping things up front. I do see that some of you have muted, and I did hear quite a lot of background noise of typing and children shouting. So if you have any children or typewriters around, just mute your phone so that you can still listen, but it won't make a noise on the call. Also, please don't put us on hold. If anyone puts the phone on hold, we hear the music that plays when you're on hold. So just mute us and don't put us onto hold if you get other calls, please, because it disturbs us on the line. Welcome everybody to the conference, to this webinar. And again, please, could you all mute your phones because there's a lot of feedback. So this is the Rooming In Are You Really webinar from CHAMPS. We are very happy to have everyone on the call here. We are also, very pleased with how we're doing so far, with especially in all areas, but in Mississippi we've had a lot of different sign-ups recently, and we have about 13 hospitals in Mississippi and several others in the process of applying. So we're delighted to do that. We produce these webinars. This is actually the last one of our June Wednesday webinars for the moment. We will start them up again in the fall. We give you a couple of months off for the summer, although we may have one or two targeted webinars for specific things that you've asked for specific hospitals or groups of hospitals. But we're going to be starting up these calls again in the fall. And we do them in collaboration with the Mississippi Department of Health, but obviously all our CHAMPS hospitals and anywhere else is very much welcome on the call. They're not private. I will say that in the fall we may be doing more of the calls more targeted specifically to our hospitals based on things that you have brought up, and we're going to be hoping for a lot more actual hospital participation so that you are going to be doing some of the presentations on these webinars in the fall and not just us from the leadership team here. I didn't put all of this onto the slides, but we do have a couple of CHAMPS announcements. As you can see, all our stuff, our website has been rearranged because we have so much material on there, but we have the two conferences in the fall, one in New Orleans. Whoever's typing, could you just mute your line, please? One in New Orleans and one in Jackson, Mississippi. The New Orleans one we've started registration for. That's on the 20th and 21st of October at the New Orleans Hilton, and it's just for CHAMPS hospitals. So if you're not a CHAMPS hospital yet, please let us know. Please sign up, and then you can join. It's for the New Orleans one is for Texas and New Orleans, and then the one in Jackson is for Mississippi and Southern Tennessee hospitals. So, and the Jackson one is November 12th. So more information will be going out about that, but everything's on our website. So, okay, so we're now going to get started with the webinar. So thank you all for coming on. And today we're going to be talking about rooming in, which is one of the very interesting things that you have to implement when you become baby friendly. Rooming in is encapsulated in step 7 of the 10 steps to successful breastfeeding. And the step says that you should practice rooming in, which means allow mothers and infants to remain together for 24 hours a day. And when we say this to people usually say, 24? Are there any exceptions? 24 hours seems to be an awful lot of time with the mom. So we're going to talk about some of the things that sort of you do and you don't need to do and how you're going to do that. And I also have left quite a lot of time at the end of this presentation for discussion because I know that this is one of the steps that people get most concerned about. It can cause a lot of kickback and feedback, and I do definitely want for you to have a chance to ask questions about this at the end of the presentation. So in terms of that 24-hour thing, what does Baby Friendly USA say? And if you ever sort of want to know what Baby Friendly USA says about anything, you need to go to the Baby Friendly USA website and look at their guidelines and criteria, which lists everything in detail that you need to know about each step and what you need to do. And you do not have to be signed up with Baby Friendly USA to access the guidelines and criteria. That document is out there for everyone to read if you just visit their website. So in those guidelines and criteria, Baby Friendly USA says that the facility should provide rooming in 24 hours a day as a standard for mother-baby care for healthy, full-term infants, regardless of feeding choice. So a couple of things around that. One is it's very interesting that, it can be somewhat helpful to you for this initiative that this step is for everybody, and that's the same as the skin-to-skin step. Quite often people, will kick back about baby friendly, that this is just a breastfeeding thing and it's too much pressure on breastfeeding. Well, it isn't just a breastfeeding thing. It's about the best standards of maternal child care in the hospital. So everybody should be rooming in as the current practice and the standard of care, regardless of whether they're breastfeeding or formula feeding. So it's just something to note and be aware of. Especially if you get feedback from people saying it's too much breastfeeding stuff, this is actually not about breastfeeding. It's about keeping moms and babies together. Now, there's this often quoted thing about 23 out of 24 hours. Baby Friendly USA has pulled back from that. There is a little thing on their website about, they shouldn't be out for at least for more than an hour a day. But I can promise you that this is not, it's confusing, but actually it's not confusing, because although they say that, what really happens is the following. If your baby in your hospital goes out of the room for some kind of a medical procedure, then clearly nobody is going to say to you that this baby needs to be back within an hour. Okay, that applies to major types of things. Our circumcision, they actually should be back within the hour. What happens often for circumcisions is that they take all the babies in the nursery at once, and baby number 1 is back in 20 minutes, but baby number 6 in line might not be back for 2 hours. So you need to make sure that the circumcisions are done like one by one, and not with a great long line of babies waiting in the nursery. But basically, they're not. No one's going to dictate to any hospital the duration that they need for any kind of a medical procedure. So that doesn't really make much difference to the 23, 24-hour thing. However, if a baby goes out for a bath or a hearing test or a blood test, in most circumstances, except for some fairly unusual ones, that's not okay. So it doesn't matter if the hearing screen only lasts 15 minutes. It really doesn't count for the rooming in. It's not allowed. You can't take them out for routine procedures. So really it is 24 hours a day in the room with a mother, except for if there's a medical procedure that has to be done somewhere else for the baby. And there are a few more exceptions which we're going to talk about now. So these are the routine things that should be happening in the room. Now, I'll preface this with saying that, you only have we're talking about passing actual baby-friendly assessment, and I know that not all of you will necessarily be headed for that, but this is, just to keep it clear, we're talking about what the assessors will look for if they actually want you to come up to the baby-friendly standard. And these different practices are all things that need to be done in the room to meet that standard of care. So the hearing screen, the pediatric exams, that means the pediatrician should be examining the baby, in the mom's room. Any routine procedures, and sometimes, you have the lab do the blood tests, also phlebotomists do the blood tests. Some hospitals, the nurses do the blood tests. But basically, any of those routine things should be done in the room. The bath should be done in the mom's room. The baby should stay with the mom at night, and those are all routine care things. And you actually can see a very beautiful picture here of one of the mothers at my hospital at Boston Medical. And this mom is breastfeeding the baby in the room, and this baby, as you can see, is being treated for hyperbilirubinemia with a paddle. They have these like blue light paddles, which you can see across the back of the baby, and that is a way to have the baby in the mother's room, even if the baby has jaundice and needs to be with some kind of light. And we also have the Billy beds at Boston Medical Center, which is the baby's crib fitted out with blue light, so that can be used in the mother's room, and they don't have to take the baby back to the nursery. Actually, you can see in the background here a Billy bed in this picture. This mom's nursing with the paddle across the baby's back, but there's a Billy bed in the back of the picture there. This mom's actually at a breastfeeding class. That's why she's not in her room. She was at the breastfeeding class, but she had all the equipment with her that would help her keep the baby in the mother's room when she went back there with the high Billy. So when can you actually take the baby out of the room and it's still compliant with rooming in? So obviously, as we said, any kind of a procedure, the baby can go out of the room, and that is not questioned, and that's fine. It does have to be documented, and we'll talk about documentation in a while, but it's certainly within all kinds of, no one's saying that you have to do procedures in the room. Oddly enough, because I don't see why you can't just sit a baby in a car seat in the mother's room, but right now, Baby Friendly's okay with that car seat test with the smaller babies, that they have to sit in the car seat and be able to toilet before they can get home. That can be done outside the room. Why they decided that, I don't know, but it's a very specific thing to the US, and that is not necessarily have to be done in the room, and that's usually right before mom goes home that they do that, so it's kind of right at the end of the stay anyway, and they're about to get out the door. So the big thing that, just skipping to the last bullet here, if mom's sick or mom goes to have her tubes tied or there's something else happening with mom that, well, obviously no one's going to say the baby needs to be left in the room on its own. So if there's something happening with mom, obviously the baby needs to go somewhere where it's been observed and protected from any other adverse events. So the baby needs to go away if it's happening to the mom. So, of course, the big question everyone always asks is, so what if mom doesn't want the baby to be in the room, especially at night? What do we do? So we're going to talk about documentation, but if the mother requests that the baby goes to the nursery at night, just like if she requests formula, you need to have education for the mother about why you're rooming in with mom, and then she has to consent or agree to do that, and then it has to be documented. So, I mean, I've traveled around the country a fair bit, and I've found some really kind of interesting and odd practices out there. And some things sort of what one would assume mean you're bound to be rooming in don't necessarily mean that. So, for example, there are a lot of hospitals, believe it or not, that don't have a nursery. And this is not, we're not talking like funky little birthing centers. We're talking big hospitals. For example, there's a big hospital in Camden, New Jersey, a very impoverished area, which has no nursery at all. And it's a very big nursery and a lot of births, but they don't have a nursery. And surprisingly, to some of us, or to those of you who have nurseries, it's not that unusual for a hospital not to have a nursery. So one would assume that if the hospital doesn't have a nursery, that babies and moms are rooming in, but actually that's not always the case. You know, quite often you'll see babies parked outside the nursing station, or they'll move them into a procedure room or something like that, because sometimes, even though there's no nursery, babies don't always room in. Although I do have to say, most of the time, no nursery dramatically cuts down the babies going out to the mother's room, and then it's usually quite unusual for them to be out. But it doesn't automatically mean that they're not out. That they're in the room if there's no nursery. And then LDRPs, you know, you would think that if the whole point of having that is to keep moms and babies together, because you stay in the same room, you give birth in the same room, you recover in the same room, and you stay there for postpartum, you would think that that meant that the baby also stays in that room the whole time, because that kind of seems to be the point, but that's definitely not the case. In some hospitals that have these LDRPs, the baby still goes to the nursery after the mom's had the baby. So I'm just saying, because often people will say to me when I talk to them about rooming, oh, well, our hospital, we don't have a nursery, or we don't have we have LDRPs, but it certainly doesn't mean that that actually is automatically guaranteeing compliance with rooming in. And then one of my more kind of amusing perspectives here, that you can have a certain amount of empathy or comprehension, certainly for hospitals that have, for example, a hospital we worked with in the Best Birth Beginnings Project, 8,000 births a year. There are hundreds and hundreds of babies, and it seems to be more efficient to bring those babies back to the nursery so that people can do all the tests at once. And by the way, that hospital did go baby-friendly, so they don't do that, but I'm just saying. It would seem to make sense that the babies come back to the nursery if you've got an awful lot of babies and it's quicker to check them. So by the other sort of extreme of that, you would think that hospitals that maybe have 2 or 3 births a week, they don't need to take the babies back to the hospital, to the nursery. That's actually not the case either. So often we go to hospitals with like maybe only one baby on the unit at the time of the visit, and when you get there, the baby's in the nursery and for the pediatric checkup, and you say, well, why are you doing the checkup in the nursery, doctor? And he said, oh, well, that's how I always done it, or it's easier or something. In fact, we also had one hospital where they only had 1 or 2 births a week, and they told me that all the babies need to go back to the nursery at 6 a.m. to be weighed. And we get ourselves into these positions, they had 2 babies in the past week, so each baby had to be wheeled out individually, into the nursery and back. It would have been just as easy to do the weight in the room, and eventually, of course, our hospital did do that. But there's not always a lot of logic to why we do these things, and so it's kind of interesting to see the different patterns as you go around the country, seeing lots of different permutations and all sorts of everyone making what in their rationale is considered a very reasonable response to why the babies aren't rooming in, but doesn't seem necessarily reasonable to people from the outside. So I think one thing that's really critical to look at and think about in terms of rooming in is prenatal preparation, because you will hear and you will tell me, I know that many, many moms protest about rooming in because they want to send the baby back to the nursery at night especially, or, you know, for whatever reason. So it's absolutely critical that mothers are prepared for this. Not only just because you want them prepared and you want your staff to be able to, you know, them to know that this is going to happen when they get there, but if you are doing the baby-friendly pathway, the assessors will ask the prenatal patients as part of the assessment what they know about rooming in. So they ask them about skin to skin and they ask them about rooming in. Has anyone talked to you about rooming in when you're in the hospital with your baby? I can tell you that even when I do these assessments, I do assessments most of the time on hospitals that think they're ready to be assessed by Baby Friendly USA, so they're towards the end of the designation phase. And when I ask mothers that question, it's one of the two worst answered questions in prenatal care. Most women have not been taught about rooming in during prenatal care. You do not have control over all the women who have prenatal care that come to your hospital, because your hospital's only going to be teaching the mothers who see your doctors in your clinics, and for some of you that may be everybody, and for others of you it may be nobody or next to nobody. So it's difficult to sort of make sure that you have universally educated women on rooming in before coming in. But the ones I'm speaking about are women who are seen by the hospital's own prenatal service, and those women have not been educated generally about rooming in. So it's no surprise when they get to the hospital and you say, oh, the baby has to stay with you, that they don't know why that would be, and it's almost setting yourselves up for disaster, because you're trying to explain it, and she's never heard about it before, and she just thinks you're not being helpful. So prenatal preparation is very, very important. People may not mention this at all, and so women come in unaware, or, you know, it's not only is it prenatal preparation, but it's also how it's presented during the prenatal period. I think this picture, this poster, comes from one of the hospitals in Detroit that we were working with, St. John's Hospital, and I have mentioned this on a previous webinar, but I'll just quickly recap. This hospital had a terrible problem, not only with rooming in, but also with prenatal education and getting women to know about rooming in. So they did this campaign where they put these posters in the waiting rooms, and they had peer counselors go into the waiting room and sit down with mom and show her different posters. This was one of them, and ask her to vote on the poster and of the week that she liked the best. And then her name was put into a draw, a raffle, and everyone won a prize. And people won prizes at the end of the week. But what was important was that they had this picture up in the waiting room, and they also sat down and talked to the mom and had her read it. She had to read the posters to be able to vote on them. And this was really nice because it gave, you know, it's kind of a catchy thing, and it gave explanations about what rooming in was for and why it was done. So, you know, that's really important. And similarly, when people present it during the prenatal visit, you need to have something very positive. And the way that I always talk about it to moms during prenatal, and usually this ends up being me talking to moms during the baby-friendly assessment, because the mock assessment, because they've never heard about it. But I look the mom straight in the eye and I say, this is your baby, and no one's allowed to take this baby out of the room without your permission. So don't let them take the baby away with you in the hospital. Don't let them. And I often say, and you're going to be a test case here, because unfortunately the hospital's not doing that right now for every mom all the time, but it's your right to keep the baby in the room with you, and they're not allowed to take it out. You can have that baby there all the time. And I've never had a negative response to that. Moms just look at you and say, oh, yes, okay, I'll do that. I want my baby in the room. Now, I've had to deal frequently with prenatal providers, and I have to say, usually it's obstetricians, it's not always, but prenatal providers will not necessarily present it in this light. And I have to also tell you guys, you know, it's really also important to present it to the prenatal provider as well, because if it's just like considered to be this new rule that the hospital's making and they've had no buy-in and no information, then they're definitely going to not be happy about it, unless you have the rare exception of the provider who's really already aware of and bought into baby-friendly. So the providers who haven't necessarily been prepared for this very well themselves will say to moms, and I've had this, you know, I've heard this information, that they, you know, be careful, because that hospital down the street, they're closing the nursery, and you're not going to be allowed to send your baby back there. So you call me, or you get in touch, or you do A, B, and C, just to make sure your baby can go to the nursery at night. So, you know, those are two ways of speaking to a prenatal patient, which will give them a very different vision of what rooming in is about when they come into the hospital. And, you know, you really have to think about how this is going to be presented to the prenatal clinics and then how the prenatal clinics are going to present it to the patients. And I just love this picture because this was actually printed in a newspaper in New Jersey advertising a brand new hospital in New Jersey. And I just think it's an amazing picture because, first of all, that the hospital would actually allow this to be out there as sort of the advertisement for a new unit. They may well be doing rooming in, but this is definitely not how you want it to be advertised, with a screaming baby in its crib, and mom looks like she's phantom texting or something, and certainly looks very disengaged. So I think that's really an amazing photograph, which was in a newspaper, and just summarizes really everything that you don't want to present about rooming in, that, you know, you're going to have this sort of horrendous experience with your baby screaming in the crib and you won't be able to use your cell phone or something. It's a very strange image, but it was used out in the press in the area to advertise this unit. I suppose people thought it was funny, but not for the same reasons that I think it's really strange and funny. So, is mom the problem? You will hear all these things, and you will definitely hear them from moms too. I mean, I'm not pretending that this doesn't exist, but mom wants rest at night. Mom doesn't want to see the tests or the heel sticks. She wants to send the baby to the nursery. I love this picture also. This is taken from my hospital a few years ago, but this is, I think it's the same mom that was in the earlier picture, actually. And here is the baby in the mother's room being seen by the pediatrician for hyperbilly. And you can just see how anxious that mom looks and the way she's looking to see everything that the pediatrician does with the baby. Yes, you do have moms who end up absolutely exhausted, but given, you know, depending on the way that the hospital works this, you certainly can get a lot more buy-in and really minimize these kinds of things with moms if you will help and work with the mother. So, you know, again, this is the things that I see as I go around. I mean, who is it that's really talking about sending the baby back to the nursery? You know, it's all in the presentation, but quite often, you hear nurses saying to moms, "Oh, you look really tired. I'll take baby Jimmy back to the nursery for a few hours so you can get some rest." And that's very, very common. And then, you know, you hear, "Oh, well, mom wanted the baby to go back to the nursery so she could rest." But it was really the suggestions coming from nursing. And I just think it's really important to make sure that we are aware of how we phrase these things and talk about these things with moms before we kind of say it's all the mom. If it is mom, then you need to educate the mom about rooming in. I mean, for one thing, some of these women think that, well, I tell you what I thought when they started, you know, they didn't room in actually at the hospital I was at when I had my baby, but they did try and encourage the baby to stay in the room, and I thought that the hospital was like trying to close the nursery because they didn't have enough money or staff, and they were kind of pushing the baby on me. That's what I thought all those years ago. And I think, you know, women have no clue why you're doing this unless it's explained to them. So you need to explain to them that, you know, they actually get more sleep if the baby's in the room because they're not anxious. And just make sure that you document that education. And then if the mom still wants the baby to go back, just document in the medical record that you've educated her about it. You have an 80% pass rate, okay? And one thing that, you know, it shows up, if one or two moms want the baby to go back to the room, then, you know, that's kind of part of the course. If you have like 50 to 60%, 70% of moms wanting the baby to go back for the room, that's not part of the course. And the hospital, the baby-friendly people are definitely going to be questioning why are those babies all going back, because that's not the norm for, or, you know, most moms to want the babies in the nursery most of the time. Either it's coming from the hospital, there's a lack of education, or there are some times when it's a local culture. Now, I really am very, very skeptical when people say culture, because a lot of stuff is also blamed on culture when it's not really culture. But I'll give you one very specific and concrete example. We worked with some hospitals in New Jersey where they had a lot of women who were Orthodox Jews and have very large families, and they had been coming to that hospital for years to have their babies, and the babies had all gone back to the nursery, and sometimes there was mom in the room with 4 or 5 other children. And definitely, you know, for better or for worse, in that group it was more common to send the baby back to the nursery at night. And that had been something that group, which was a very close-knit community, and they all knew the hospital, and they'd all been coming there for decades to have their babies. That was the norm for them, and that was kind of very difficult to sort of talk with that specific group of people. And what actually the hospital did was they involved the rabbi, and they had some community education with moms and talked to them about it. So, sometimes there are those kinds of settings where there is something very specific to that hospital or that community that is leading to this. And obviously, you're going to have moms who have multiple children who've had them at the hospital and expect that to be more likely to be resistant to the rooming in. And you may end up, taking their babies back to the nursery, but it should be a few moms some of the time, not most of the mothers most of the time that it's happening with. And then just in general, with the staff and the rooming in, this is something that's really important to sort of point out. At this point, most of you on the phone call are probably not rooming in 24 hours. You may have tackled some of the things like, the hearing test or the bath, or some of those things have been doing in the mom's room, but some of them probably at this point in your journey are not being done in the mom's room. And yet we're telling mom she has to keep the baby. So it's a complete double standard, because what we're saying to mom is, well, when we feel like it, we can take your baby to the nursery to do something to them. But when you feel like it, you can't send your baby back to the nursery. And that's just really kind of not. Therefore, it's a double standard, and it's not making the point. You can't say, oh, it's really, really important to this hospital to keep moms and babies together if you then keep taking them out. So you need to show commitment to the process so that mom believes you when you say, we really think the baby should stay in the room all the time, because if you keep taking them out for your purposes, then clearly you don't really believe it. So you should see, as you will move towards doing more stuff in the room, that is therefore expressed practically as the norm in the hospital, and that the mom becomes more used to that, and that then, when you say to her, well, we really think you should keep the baby if you can, because it's really good for you, she'll believe you. If you keep taking the baby out, she's just not going to believe you. There's also some issues around clinicians, nurses and doctors that are specific to rooming in. Often, nurses, and I say nurses because it's usually the nurse that's in this position, do believe that mom needs rest and that the baby would be better in the nursery. And there are definitely some extreme conditions, like a mom who's really had a bad experience after a cesarean or is really, really tired, where medically it's safer to have the baby cared for while the mom recovers. But, in terms of the healthy term, normal deliveries, the evidence shows that the mom actually sleeps better when the baby's in the room. She's actually more relaxed, and she's not anxious about the baby. There is also definitely an issue around certain clinicians doing tests in the room that they're just not comfortable with. So, if the nursing staff has always done the blood draws in the nursery, it's quite intimidating to have to do that in the room with the parents who are probably anxious watching. So it's definitely a level of anxiety among nursing staff when they're doing just routine work that it will upset the parents. And I think, it's this is just very common. And I'll just quote a specific example. Last month I was in a hospital in Oklahoma. We were doing a mock assessment, and we saw a nurse taking a baby back to the nursery, which, guys, if you're doing an assessment or a mock assessment, don't have the assessors meeting a nurse taking the baby back to the nursery, because they're bound to ask what's happening, okay? So be a little bit savvy about this. But anyway, here's Nurse A driving this baby down the hallway back to the nursery. So I said, well, could you tell me why the baby's going back to the nursery, please? And the nurse was very, wonderful nurse, and she said, oh, Mom was really worried about doing the blood test in the room. She really didn't want to see that, so we're taking the baby back to the nursery. So I'm okay. So then I said to the person from the hospital who was hosting our site visit, let's go and ask the mom. So we went in the mom's room and we said, oh, could you tell us why your baby's not here? And she said, oh, well, the nurse came and told me that I really, they wanted to do blood tests and it wasn't a really good thing for me to see, so she wanted to take the baby back to the nursery. And I really don't think that either of them was not telling the truth as they interpreted it, but it was definitely not a case of mom saying, please remove the baby for these tests. It could have been presented to her, I don't know, more detail than what we garnered, but it could easily have been presented to her, this is going to be very painful for the baby. You probably don't want to see this. The baby's very stressed. I remind you that within a few days of the mom going home, she's back at the pediatricians and they're doing shots and things within the first, weeks. And the mom is definitely going to spend the rest of this child's childhood seeing this baby on child have shots and blood draws. So, there's no reason to, if you protect her on day one, she's certainly not going to be protected at week 2. So it's not particularly peculiar for parents to be in the room while minor things like blood draws are being done. So I think that is something to really carefully bear in mind. And something very similar happens with physicians and pediatricians doing the exams in the room. It may be supposedly more efficient to do them in the nursery, and that's what they're used to. But also, doing the exams in the rooms, they have to talk to the patients. Now, pediatricians definitely talk to patients because they see them later on, as soon as the baby's discharged. But they kind of probably have it more patterned down, and the parents are more anxious during the time that the baby's in the hospital. So it is also a level of added anxiety and new kinds of communications that the doctors are going to have to work on too if they're doing the baby exam in the mother's room. So that's also something to consider. And then there are definitely practical issues, which is why we don't recommend you do rooming in all at once overnight. There are practical issues like, where are we going to bathe this baby? The water's not warm enough in the room, or there's no safe place to bathe them in the room. How are we going to do the hearing tests? Because the company that we hire to do hearing tests only will do them outside of the room, et cetera, et cetera. So there are definitely lots of things that you have to overcome, and this step, is something that you really can only do it slowly and step by step, and you can't do it. It's very, very difficult to implement it all at once because something inevitably is going to go wrong. I think one of the things that you will have to convince individuals about in your hospital is why their little bit matters. So, for example, doctors have said to me in the past, and, God bless them for being honest, and they say this. I'm like, look, it takes me 15 minutes to do that exam in the nursery. I just don't believe that it's going to make a difference to this woman's breastfeeding if I take that baby back to the nursery and I do a 15-minute exam and then take it back to the mom's room. And, that doctor is right. It isn't going to make a difference, probably. I mean, we haven't got absolute evidence, but it makes complete sense that 15 minutes in the nursery being examined by a doctor is very unlikely to disturb forever the breastfeeding relationship of that mom and baby. However, it's not that simple because especially if it's the doctor that's taking the baby back to the nursery for the exam, everyone sees that doctor take the baby back to the exam, to do the exam there, and then the nurse is going to say, well, the doctor's doing the exam in the nursery, so I'll just quickly do a bath in the nursery. And then, maybe all the hearing screens are done outside of the mother's room, and et cetera, et cetera. And before you know it, the baby's going out 10 times a day for different things, and even if it only takes 15 minutes each, definitely at that point, yes, it is going to interfere with the breastfeeding relationship because the mother and baby are constantly being separated and all sorts of normality and cues and all those kinds of things are lost. So it matters because each individual incident is part of a bigger picture which does make a difference. And I think it's really worth sort of taking that apart with people and explaining to them why it matters, and especially people who have leadership roles like, doctors. I do know that, well, I won't go into that. But anyway, doctors can make a big difference because everyone's watching the doctor and what does the doctor do. So just to kind of talk a bit about some of the documentation that you have to do around this rooming in. So just as a reminder, when Baby Friendly comes to do your assessment, just like with everything else that they talk about to patients, rooming in is something that they will ask. Well, they'll ask your prenatal patients to describe it, and they will ask your postpartum patients, has anyone taken the baby out of the room during the stay? Okay? And if they say yes, then Baby Friendly is going to want to figure out what happened. If it was a medical procedure or something that was absolutely necessary and it's all it's all documented, you're off the hook. But if the mom just says the baby went out for a test, which is very often all she says, a test, it could be heel stick, it could be a spinal. The mother may not really get the difference at that point. So you need to be covered because if it went out for a spinal, you're off the hook. If it went out for a heel stick, you're not. So everything has to be documented. So the assumption with rooming in is that is the norm, that the baby and the mother will be together all the time unless something untoward happens. So what you need to figure out is how you're going to document the egress. When the baby goes out of the room, where is that documented and how is that documented? And it needs to be documented. Document when the baby leaves the room and document it when the baby comes back. And then you've got like it's all there, and it just also really raises awareness to be documenting. I mean, really, you should kind of know where your babies are all the time. And those of you who are coming from the opposite model, which is nursery, often it's documented when the baby goes out of the nursery because you don't want to lose the baby anywhere. So the documentation is fairly important in and of itself. You want to know where babies are at a given moment or where they were. So you need to document that. And each time they go in and out, you need to document it, which is an awful lot of documentation. It would be actually easier to leave them in the room, and that can be something that you can talk to the nursing staff about too, because if they're having to document every single time the baby goes out and the baby's going out for all this routine care, they're going to spend an awful lot of time in documentation. So it would be easier to leave them in the room, and then you can cut down on your paperwork as well. By the time you've taken the baby out, given it a bath, documented it going out, then you bring it back, document it going back, you could have done the bath in the room. This is just a very clear example of a documentation, and I use this one, which is actually not a valid reason for being out of the room, but maybe many of you may still be doing it this way, so you can start practicing on your rooming in documentation right now, even if the reasons for them going out are not right. So you want it to be part of the ongoing medical records, and I know you're all working, the CHAMPS hospitals are all working with Emily Taylor on documentation. So anything that Emily says supersedes anything I'm going to say in terms of how exactly you physically put it into the medical record. That's Emily's the person to talk about that. But what we want to see is documentation, for example, that at 10 o'clock in the morning the baby left the room for a hearing screen, and at 10:15 the baby came back. It's not an acceptable reason, but the documentation is correct. And many of you are at that point where babies are not leaving for acceptable reasons, but at least you should be documenting why they're leaving. And then as those, as you chip away at these different things, once you don't do the hearing screen in the nursery anymore and you're doing it in the room, your need to document that will go away. But you do need to document each incident of when the baby leaves the room. Now here's an example about the mom asking for the baby to go back to the nursery for night. The mom was educated on the benefits of rooming in and exclusive breastfeeding, and how rooming in can interfere with breastfeeding or can interfere with mother-baby care and the mother caring for the baby. But mother says, no, I have to have that time. So you must document it and back it up in the in the report. And again, if baby friendly comes down, it's never, I have to be honest here, maybe Emily, I don't know if Emily's on the call, but this thing about whether this baby falls into that kind of, okay, well, you documented it, but you didn't pass, is a little bit academic. I think basically you should probably clarify that at some very late point in the process when you're doing the interview with Baby Friendly USA. But the bottom line is it shouldn't be more than 2 out of 10 babies anyway where that's happening, so it's almost immaterial. If it only happens to one baby, you'll pass anyway because it doesn't. It's 10 babies and one of them was in the nursery. You're still passing at 80% rate. I'm not totally sure, honestly, if a baby is all documented, whether it counts against you. I believe I've heard Baby Friendly USA say it counts against you anyway, but it's something that we need to clarify with them, and also you need to really be sure that only a couple of babies out of 10 this is happening to them anyway. It shouldn't be. You will not pass if you've got documentation in the medical record that 6 out of 10 babies had to go back to the nursery the night before. Clearly something's going wrong with the process. So it only works to a certain extent, but you certainly need the documentation, because the Baby Friendly USA will go to the record and they will check what happened. And if there's no documentation at all of the baby going out, but the mother says the baby went out, then that's definitely a fail. So just to remind you, after all this rather traumatic stuff, and again, I've mentioned this before, but there are stages of change, and these can be directly applied to baby-friendly 10 steps. And the state that most of you are starting from in the CHAMPS project is a kind of equilibrium, that people are all happy with the way that it's being done, or most of them are happy most of the time with how it's being done. And then we come in and talk about baby-friendly, those of us who are from the outside or those of us who are advocates inside, and people basically just ignore us. And then we don't go away, so everyone starts to get upset and angry, and then bargaining. And this really applies as rooming in. If you have a system where maybe the babies are already in the nursery, like at the beginning, for 4 hours before they go to mom's room, which, of course, this is all part of rooming in too, and that is definitely not something that will be accepted, that the babies go to the nursery for a set period of time and then go out to mom. There's no evidence anywhere at all in any kind of literature that is beneficial or necessary. So that will not be a pass. And you will find at this point, when you say, oh, well, all our babies are in the nursery for 4 hours, people will say, well, let's cottage and make it 2 hours then? Is that a fair deal? And unfortunately, it's not a fair deal because you need to eliminate the practice altogether. So you have to be very, very careful with bargaining because it can take a long time to set up an alternative system, and then if you then have to change that again because you really, even when you set it up, you knew it wasn't something that was a long-term solution, you're going to upset people all over again because they're going to have to change something that you agreed on. So just be really careful with rooming in that you have a consistent message about, no, the babies need to be with mothers all the time. So we can't say, okay, we'll do the hearing screen in the mom's room, but we'll do the bath in the nursery. You can't bargain, unfortunately, because it's an absolute. So that you know, it kind of sounds bad, but there's going to be a way to have to do it, and that's going to have to be how it's done. So you can't bargain at that point. And then people say, what is going on? They get chaos, and they get really fed up and depressed because they think that, you know, everything's done for. But at some point, they resign themselves to the change. And then I will tell you, you'll end up having to talk to people all over again because you were talking to them before, but no one was ready to hear it. And now suddenly everyone is willing to hear it and people are willing to sort of do it, and at that point you'll have to remind them exactly what it is they're supposed to be doing and why they're supposed to be doing it and how to educate the mothers. And that is when people start to recognize that actually moms and babies stay together and they're happier that way. And I just want to end it with a little sort of personalized story of a hospital that I worked with out in the middle of Navajo Nation. It was a very small hospital, really out in the middle of nowhere in the desert, very few births. I think they had about 50 births a year. And they were not practicing rooming in. And we went out there. I went out there with the CMO of the Indian Health Service, and we did mother interviews. And we just had this amazing young mom, and I'll never forget the interaction. She spoke to me and the CMO. You know, there's a kind of intimidating situation. The CMO's in major uniform with all sorts of stripes and stars on her, and myself, and she just basically told us that when she was in the hospital and the baby was taken out of the room, she was really, really scared because she said, I could hear him crying down the hallway for 4 hours and I couldn't get to him. And she said, and I was just really worried they were going to mix him up with the other babies. I don't honestly believe, guys, there were any other babies in the hospital at that time. They had like 1 or 2 births a year, but that was a real fear to her. She was really, really worried about the baby crying. She could hear the baby. She couldn't get to the baby, and she thought they might bring the wrong baby back. And a few minutes later, myself and the CMO, we went into the hospital CMO office, and we spoke to him. And almost the first thing that came out of his mouth was, well, the Navajo don't want the babies in the rooms with them. And, you know, the incompatibility between the interview that we had just done with the mother and what the CMO said in a sort of pat way was just appalling to me. And I think that we have to really, really think about, do we know what moms really want? If we are presenting it this way, if this is how it's been done forever, you know, if you absolutely interview the moms and talk to them in the right way about it, you will not be able to say that the Navajo or this group of women or that group of women do not want the baby in the room with them. I think it's something that you really have to consider, and I'll never forget that interaction. And, you know, we both, myself and the other doctor, we just almost fell over on our chairs that this person could say that when we just come out of this interview with this mom who was really, really worried about having had the baby taken out. So on that note, I'll end the presentation, and I would be delighted to take any questions, comments, feedback. We have another 15 minutes, so please go ahead, and we can unmute the lines, Laura, or you guys can unmute your own lines, and then we can hear any questions that you have to say. And if you can, I know that sometimes some of you can't speak up. You can always type your questions into the chat. So questions, comments, feedback, worries?
Move it. I was like,
hello?
that it got destroyed. I don't know.
Hello?
So, Anne, this is Laura. I just wanted to let everyone know that I did unmute your lines. So if you do actually want your line to be muted, you can go ahead and mute it yourself now.
Anne?
Yes.
This is Mary Randolph with University. I was a little bit late getting on. I had to use my home email to get on. The link is, am I doing something wrong on trying to get on the webinar? And another question, are you going to send us the slides?
Okay, so, you can probably email Laura about technical stuff after, unless Laura can answer that quickly. All our slides are all posted on our website. So
Okay.
if you have any questions, just email the CHAMPS team, and we will send you the link. But it's www.champsbreastfeed.org, so you can just go to the website, and it may not be up there right now, but within a day or two it will be there, and all our other previous webinars are on there.
And this
Okay.
is Laura, and there'll be a the recording will be on the website as well. And all I have to say about, like, the way we have registration set up now, we want to make sure that people register so we can just see who's on the call.